Awesome. Well, thank you for allowing me to speak today at this conference. It's been great to hear a little bit about everyone's experience being queer in computational biology. My name is Curtin. I'm here to talk about relative subpopulation abundance and trajectory inference, how they reveal population ecologies in multi-regional sampling of high-grade glioma. First, I wanted to just briefly talk about my academic trajectory. So I started in the UK, where I'm from, at the University of York. I did an integrated master's in mathematics, and it was there that, so towards the end of that degree, that I came across computational biology or mathematical biology, and then so I did my PhD in mathematical oncology, which is my first exposure of sort of math applied to cancer. And it was also there where I came out as a gay man. I happened to be put in university halls with two other gay men, so it's kind of created a nice safe space for me to do that. And now I'm a bioinformatician over in the US within the mathematical neuro-oncology lab at Mayo Clinic in Phoenix, Arizona. I'm quite fortunate that Mayo Clinic has a queer employee resource group, so we have representation at Pride. You can see in that last photo there. So for those who might not know, high-grade glioma or glioblastoma is some of the most aggressive primary brain tumors out there. Glioblastoma particularly has a poor median survival of only around 15 months after diagnosis. It tends to be has a high incidence in older patients, as well as a slight sex-biased incidence towards male patients. Part of the reason it's so aggressive is it's very heterogeneous, both within and between patients, and also the cells are can be quite infiltrative. So during surgery, it's impossible to remove all of the cells, so recurrence is unfortunately inevitable. Also, with the sensitive location of the tumor being in the brain, opportunities to collect tissue biopsies are quite limited because, as you can imagine, surgeries are quite intense and intensive recovery for the patients to undergo. So therefore, the disease is usually tracked using MRI for things like treatment response and progression. And so we want to try and characterize the spatial cellular heterogeneity, both within and between patient tumors for high-grade glioma. So to do that, we have established this biopsy collection protocol here at Mayo Clinic, where we use intraoperative neuronavigation systems. The specific one we use is the Stealth machine by Medtronic, and that's able to take a preoperative MRI and register it during surgery to the patient's brain. So hopefully you guys can see my mouse. So the Stealth screen looks a bit like this. The surgeon is able to tell us with a specific tool whereabouts they are about to collect a sample from. We ask the surgeons to collect ideally 8 samples per patient and try and get a representative spread around the abnormality. These samples are then flash frozen inside the operating room or placed in formalin for other analyses. The flash frozen samples are then undergo whole exome sequencing and bulk RNA-seq. And of course, we also track patients' metadata like patient sex, age, survival, and we put that in our database we've coined PatientView. So with these bulk RNA-seq, we're interested in sort of seeing the abundance of different cell populations that might be present. And we can do that with this algorithm called CyberSort, which is a deconvolution method. That's able to take single cell RNA-seq as a reference. So the single cell RNA-seq will undergo typical clustering algorithms to get signatures for different cell populations or cell states. And we can then apply that signature matrix to our bulk sample. Obviously, our examples aren't coming from the lung, our samples are coming from the brain. And they give us estimates of per sample where we can see which populations appear and in which sort of relative abundance. So when we apply that to our data, we have 18 different populations. We have 6 glioma related populations that align to the transcriptional subtypes of glioma. But we also have immune cells. We have some tumor-associated macrophages, myeloid cells, and T cells, as well as some other cell types like different astrocyte signatures, endothelial cells, neurons, oligodendrocytes, and oligodendrocyte progenitor cells. And with the novelty of our data, we're able to stratify these by different imaging regions that are typically present in high-grade glioma. These are, you can see on the right here, in red, I've outlined sort of the non-enhancing or NE region, which is typically associated with edema and inflammation and sort of low tumor cell abundance. The green region here is where gadolinium contrast agent has leaked out of the blood-brain barrier, and that is typically associated with high regions of sort of dense tumor. And then the blue region here in the center, typically in the core of the tumor, is more sort of dying or dead necrotic tissue. And when we split our cybersort predicted populations by these regions, we see that some tumors subtypes increase as you sort of go into the core of the tumor, and some decrease. We see some quite reassuring signals too that there's more neurons predicted towards the outside of the tumor, and more normal astrocytes as well. And alongside our deconvolution methods, we can also use trajectory inference, which we do with an algorithm developed by the Trapnell lab out of UW called Monocle. And this takes sort of our complex high-dimensional RNA-seq data, plots it on an independent components analysis axis, and also does a reverse graph embedding to find a graph that links up all the different samples and assigns them this value called pseudotime, which is sort of a surrogate for how far along this trajectory each sample is. And when we apply that to our data, we currently have 202 samples from 58 patients. We see that samples with low pseudotime start off on this left sort of end state, and as they develop, they diverge at this bifurcation point towards either this top right state or this sort of bottom state here. Again, we can split this up by our different imaging regions that I introduced earlier. And we see that on the left, with the sort of low pseudotime values, are more in the non-enhancing on the periphery of the tumor. And then we see significantly more of a contrast enhancing, these green associated samples, typically associated to dense tumor, appearing at these end states. And then as you come even further into the disease, into the center, you see that the necrotic samples cluster solely on these end states here, which kind of support this idea of this graph, being meaningful to what we're seeing. Monocle also gives us transcriptional states that it clusters by itself that do tend to align with sort of the branches of this graph. And when we split our cybersort predicted populations by these states, we see a lot more significance come out, suggesting that Monocle is better able to determine different population ecologies as compared to just sort of the classic imaging regions that clinicians typically look at. Then when we combine these results together into a large heat map, I first ordered samples by the monocle predicted state that they were in, and then within each state ordered sort of by the pseudotime that monocle spat out. On the sort of all the red and blue here, each row is a different population. And we see red is high, blue is low. We see that sort of these nice clusters come out of this heat map, which suggests the different population ecologies for the disease. It's highlighted here in yellow. It's important to sort of be able to characterize these because typically, although these transcriptional states of glioma are fairly well known now, it's not really known or widely accepted in the community which immune cells and which sort of other different cell types cluster with these transcriptional subtypes, or where they live. So we're kind of getting in a step in the right direction towards that. Data collection is ongoing, but yeah, this is where we're at. And this work is also a part of a larger Center grant that we were awarded last year called the Mathematical Oncology Systems Analysis Imaging Center. That's quite a mouthful, so we just call it Mosaic. We're just finishing up our first year of this grant, and as you can see, there's a lot. I don't expect you to take in all of this figure here, but we're trying to understand the different tissue states of glioma and also how treatment might influence the transition between these different states and how we might be able to take advantage of that for better treatment outcomes in the future. So with that, here are some pictures of Arizona and the lab which I'm in. Dr. Kristen Swanson is the PI of this lab, and I'd also like to acknowledge everyone involved in this work. Also to my funders, the NCI, who awarded us that center grant last year. And thank you for listening. I'll take any questions.
Thank you, Lee. Any question from the audience? I do have one question. You mentioned Very nice, very nice talk. You mentioned that survival, it's around 15 months, I guess, from diagnosis.
Yeah.
I wonder if this is because symptoms appear when the disease is already well progressed, and therefore, I
Hmm.
guess, are you able or do you have any candidates of markers that medical doctors could check for in a more routinic way and detect maybe disease earlier before symptoms are, I mean, the common symptoms appear? Is it some possibility?
Yeah. Um, yeah, it would be great if we could. It's a tricky area because yeah, symptoms typically present. It depends also what lobe of the brain it's in, 'cause it might present as sort of like a motor issue. Like patients might suddenly feel weakness on one side of their body or something, or if it's near language, it might be slurred speech. It might be so the variety of things. Um, and also there aren't many well-known sort of like blood markers for circulating tumor DNA that might be present for high-grade glioma. So typically, it's only found early if a patient just happens to get an MRI for some other reason. Um, Short of sort of scanning people who are at high risk, like if maybe you might want to target sort of older male patients, there is some evidence too that it might be more predominant in white patients, although yeah, that's maybe a little less clear. Um, Short of doing that, I'm not sure if there's any sort of movement towards that, but it would of course be great.